Good morning, my dear students. We are coming into the fifth topic of discussion. This is a fifth part of the topic of discussion on autonomic nervous system. And this is going to be the classification of sympathomimetic drugs. Now, sympathomimetic drugs can be classified in various ways. The pressure agents, those are the noradrenaline, ephedrine, dopamine, phenylephrine, these kind of things. The cardiac stimulants, which will stimulate the heart, those drugs are adrenaline, isoprenalin, they will actually increase heart rate. Dobutamine, this is something different. It's a selective beta 1 agonist, but change in heart rate is not that much prominent. Bronchodilators, isoprenalin, salmeterol, salbutamol, formoterol, these are bronchodilators. So those drugs are basically used in not in cardiac condition, but rather they are used in bronchial asthma, and they are not only used as a in case of acute asthma, they are also used in the treatment of chronic bronchial asthma. The nasal decongestants, as per their mechanism of action, these phenylephrine, silometazoline, and they causes constrictions of the blood vessels, and therefore it will prevent the running nose. But long-term use of this may lead to vasomotor rhinitis, and that is the problem with these kind of agents. The CNS stimulants, which almost it's not a banned drug, but people are not accepting these kind of medications nowadays. One such example is amphetamine. And the anorectics, which are basically given to decrease the body weight, but due to some death, many of the drugs are not probably used due to this particular indication. Such drugs are sibutramine, fenfluramine, and on the basis of the fact that uterine relaxants and the vasodilators, that means the tocolytic agents, which are causing showing tocolytic action, the relaxation will lead to the delivery of the fetus is going to be delayed due to the use of these drugs, and those drugs are ritodrine, isosucciprine, salbutamol itself, and talbutamol. But you can classify these drugs in another way. This classification is pharmacologically more relevant, and that is the direct acting agent. That means directly they are acting on the receptors, whether it's alpha or beta receptors. And such drug again can be subclassified into two types: catecholamines and non catecholamines. The catecholamines are norepinephrine or noradrenaline, then comes the adrenaline, then comes dopamine, this dopamine. So these are all agents which are out of this, these dopamine, noradrenaline, and adrenaline are endogenous agents, and they are catecholamines. But synthetically you can prepare this kind of things, and one such example is isoprenalin. All of them are directly acting agents. They are called directly acting agents because they have direct action on alpha and beta receptors, or alpha or beta receptors. The second one is indirect acting agents, and the example is tyramine and amphetamine. Amphetamine is being mentioned over here. So this is basically indirect acting. Why it is called indirect acting agent? Because it is acting on the presynaptic alpha 2 receptors and basically increasing the release of noradrenaline from its nerve terminals. It has no direct action on the receptors, hence it is called indirect acting agents. And the last one is basically called the mixed acting agent, that is ephedrine. What does it mean? It means that it has both type of action. It will act on the receptors as well as it will act on the that nerve terminals and the alpha 2 receptors, and they are increasing the synthesis of noradrenaline. So the direct acting agents, basically the endogenous and exogenous, obviously the catecholamines. The endogenous means they are produced inside your body, and those drugs are dopamine, noradrenaline, and adrenaline. The synthetic products are dobutamine, isoprenalin. indirect acting agents, they are mostly synthetically prepared, and they are tyramine and amphetamine. And mixed acting agent, the example is ephedrine. Tyramine, amphetamine and ephedrine, all of them show tachyphylaxis phenomenon, which is also known as acute tolerance, which you read in general pharmacology. And the explanation I had given while telling you about those drugs. Whereas the non-catecholamines are also direct acting agents. They can be alpha 1 agonist, that means they have action on alpha 1 receptor like phenylephrine, used in eyes. The beta 2 agonists like terbutaline, salbutamol, salmeterol, formoterol, they are used in bronchial asthma. Alpha 2 agonists, they are actually decreasing the release of norepinephrine from the presynaptic terminals, hence they are effective in hypertension. So those drugs are clonidine, methyl dopa. It's not being mentioned here. Those are clonidine and methyl dopa. And lastly, the nasal decongestants, which are being mentioned over there, xylometazoline, phenylephrine, nafazoline, this kind of drugs. Now, if we compare indirect with the direct sympathomimetics, we can clearly differentiate between the two. The response of indirect sympathomimetics are such that denervation of the postganglionic sympathetic fiber will lead to the loss of uptake 1 is going to be decreased and the upregulation of the postsynaptic receptors. But the response of the directly acting sympathomimetic in this case, I mean denervation of postganglionic sympathetic fiber, it will be increased. So the response of adrenaline, noradrenaline will be increased, whereas indirect acting drug like amphetamine, tyramine will be decreased. The pre-treatment with reserpine-like drug, that means reserpine is responsible for blockage of vesicular uptake, norepinephrine depletion, receptor upregulation. Response to indirect sympathomimetic will be definitely, their action will be decreased. In case of direct, they will be slightly increased. Whereas pre-treatment with cocaine is basically blocking the neuronal uptake of norepinephrine. So the effect of direct sympathomimetic will be increased, whereas that of indirect sympathomimetic will be decreased. Now comparison between catecholamines and non-catecholamines are such that catechol means the ring, benzene ring, which is having hydroxyl group at the 3 and 4 position. If it is not in these two positions, if in the different positions, then they are called non-catecholamines. So the blood-brain barrier can be crossed by the catecholamines, non-catecholamines, because they are non-polar. They can cross and CNS effects are present. So most of the non-catecholamines like the beta 2 agonist, salmeterol, salbutamol or phenylephrine, these kind of drugs, methamphetamine, they will cross blood-brain barrier. But the polar drugs like the adrenaline, noradrenaline, they do not cross because they are polar compounds. The metabolism is such that catecholamines will be metabolized by MAO and COMT, monoamine oxidase at cytoplasm, and COMT, catechol-O-methyl transferase, at the level of liver. Whereas in case of non-catecholamines, they are resistant to both the enzymes. Duration of action is short in case of catecholamines. It is long in case of non-catecholamines. Orally, the catecholamines are not effective. They are mostly given via injectable form, whereas non-catecholamines are, the oral preparations are available and they are pretty good. I mean, the actions are present. So if you summarize the action of the adrenaline and related sympathomimetics, we will again go back to that slide where we are trying to demonstrate the action of both cholinergic system and adrenergic system with the help of blue and red color respectively. So the peripheral excitatory action, that is the alpha receptor action, that is leading to contraction of smooth muscle, dilatation of pupil, then comes your pilomotor reaction, contraction of GI sphincter, constriction of skin and mucous membrane, and increase in peripheral resistance, increase sweat secretion of pump. And cardiac beta 1 and beta 2 receptor action, especially beta 1, it will increase heart rate, conductivity, and it will increase myocardial contraction, as well as it will increase myocardial oxygen consumption. So remember this, these kind of drug like adrenaline, they are increasing myocardial oxygen consumption. So in case of a problem like angina pectoris, where myocardial oxygen consumption is already increased, you should not prescribe this kind of medication. Peripheral inhibitory action due to stimulation of beta 2 receptors, that causes bronchodilation, relaxation of the detrusor muscles of the bladder, dilatation of the vessels supplying skeletal muscles, and uterine relaxations. What are the metabolic effects being seen in the red color? Increase in plasma free fatty acid, it will inhibit insulin release, and it will increase glycogenolysis and gluconeogenesis, which will actually increase blood glucose level. So they are actually helpful to decrease or counter regulatory hormone when the blood glucose level is increased. In case of CNS, there will be respiratory stimulation, there will be decreased appetite, as well as increased wakefulness. Whereas the potassium level, the drive of potassium in the red cell and the muscle cell due to stimulation of beta 2 receptors can be seen in case of these drugs. In general, alpha adrenergic system is excitatory in nature except in intestine, and beta adrenergic action is inhibitory in nature except in heart. And alpha and beta receptor stimulation causes basically gut relaxation and cardiac contraction respectively. Now there will be dose dependent phenomenon which can be observed with adrenaline as well as dopamine. Adrenaline will show beta 2 action at a very small dose, 1 to 2 microgram dose, and it will lead to vasodilatation and fall in blood pressure. Whereas at a therapeutic dose 2 to 10 microgram per minute IV infusion, beta 1 and beta 2, there will be increase in heart rate, increase in blood pressure, and more than that, more than 10, it will lead to alpha 1, specific alpha 1 action. Similar action is been seen with dopamine, where dopamine will show its effect on D receptor, D1 receptor, and causes renal vasodilatation, and therefore that is happening at a dose of 1 to 2.5 microgram, and then above that level 2.5 to 10 it will have action on beta 1, above 10 it will show action on the alpha 1 receptors. So if we compare the hemodynamic effects of the catecholamines, not the non catecholamines, we are talking about catecholamines, then we will see that dopamine, they have their own receptors D, beta 1 and alpha. Heart rate will be increased, cardiac output, arterial pressure, all are going to be increased, but there will be usually very little change in peripheral resistance. Whereas noradrenaline, they have action on alpha 1, 2 and beta 1. There is no beta 2 action. No change, or rather there is a relative bradycardia, heart rate is decreased, and after that probably there will be no change. The cardiac output is not going to be changed, arterial pressure is a little bit increased, and peripheral resistance is increased. So mean arterial pressure is changed more with noradrenaline. In case of adrenaline, all alpha and beta receptors are involved, heart rate is increased, cardiac output is increased, arterial pressure is increased, but peripheral resistance may decrease. So that may lead to sometimes fall in blood pressure. Isoprenalin will only act on beta receptor, specifically beta 1, and this will lead to increase in heart rate, but beta 2 action will lead to fall in blood pressure. So peripheral resistance is decreased and the cardiac output is increased. Dobutamine, which is basically a beta 1 selective agent, agonist, it will not change, there will be no change in heart rate. This is a peculiar thing because of counter regulatory alpha action, and the cardiac output will be increased, arterial pressure is basically there is no change, peripheral resistance also not going to be changed or decreased. Hence dobutamine is almost a drug of choice in case of intractable heart failure, because without increasing the heart rate it is changing the cardiac contractility. Sympathomimetic with predominant alpha 1 adrenergic receptor stimulating effect reduce heart rate, reflexly, and one such example is phenylephrine. Now I'm coming to adrenaline, which is basically a natural catecholamine. It stimulates all the receptors alpha and beta. It has its therapeutic uses. In anaphylactic shock, it is given as a life-saving drug. 1:1000 strength, 0.03 to 0.5 ml, and at an interval of 20 minutes, given via subcutaneous or intramuscular route. In the cardiac arrest, adrenaline hydrochloride injection 1:10,000 dilution is given 5 to 10 ml repeatedly every 5 minutes, and it stimulates spontaneous cardiac contraction, raises peripheral resistance. It has another therapeutic use. It will prolong the duration of local anesthetic agent like lignocaine. So, why lignocaine is combined with adrenaline? There are three reasons. Lignocaine, the absorption of lignocaine is decreased due to vasoconstrictor action of adrenaline. Secondly, the metabolic product of lignocaine will be produced gradually, hence the chance of toxic effect will be minimized, and adrenaline will form a bloodless field. So, therefore, before dental surgery or any kind of local surgery, a combination of lignocaine is to adrenaline at a ratio of 1:80,000 to 1:120,000 is usually given as a local anesthetic. It is used to arrest bleeding from the superficial vessels, and it can be applied topically. The adrenaline can be applied topically, and that's why it is also known as styptics. So, or the other name is local hemostat. The kind of adverse drug reactions we are seeing with adrenaline are restlessness, palpitation, tremor, anxiety, precipitation of angina pectoris. So, all this can be seen with this drug. Very severe reactions are cerebrovascular accident, cardiac arrhythmias, more common with halogenated anesthetic agents, which sensitize the autonomic tissue or heart. Now, obviously, there are certain drugs which will block the action of adrenaline, and those drugs are the alpha blockers and beta blockers. They are called sympatholytic agents, and I will show you the name of the drugs at the end of this presentation. Noradrenaline, which I already mentioned, NOR stands for nitrogen ONHI radical. That means there is no methyl group at N. It is a natural catecholamine. Pharmacological effects are heart rate is in isolated rate. It is increased in intact preparation. It does not show vasomotor reversal of Dale phenomenon because it lacks beta 2 activity. The vasomotor reversal of Dale phenomenon is seen with adrenaline alone. Noradrenaline can be used in case of hypotensive state to raise blood pressure. It can be given in hypotension after spinal anesthesia and after surgical removal of pheochromocytoma to maintain vascular stability and tone. Side effects are similar to that of adrenaline, but they are less pronounced and less frequent. Preparations are basically like noradrenaline bitartrate, or it is diluted in 5% dextrose solution and infused intravenous slowly at a rate of 2 to 10 microgram per minute. The preparations like dopamine is another one which is coming into the category of directly acting natural catecholamines. It's a natural catecholamine, acts as a central neurotransmitter mainly for control of movements. So, absence may lead to, in the substantial area, may lead to Parkinson's disease. But it is the immediate precursor of noradrenaline. It is rapidly metabolized by monoamine oxidase and catechol-O-methyl transferase and have a very short half-life of about only 1 minute. It is ineffective orally, therefore levodopa preparation is given in the oral form, and it is administered via IV infusion. So, it has a dose dependent action. At the very small dose, it will increase synthesis of cyclic MP, act on D1, vascular smooth muscles, renal tubular cells are involved, promotion of sodium excretion, dilatation of renal and mesenteric blood vessels with cerebral and coronary one can be seen. Dopamine and phenyldopam are the basically the examples who are acting on dopamine 1 receptor, and the antagonist of such is phenothiazine and xanthines. These are all the drugs used in schizophrenia. So, decrease in dopamine may lead to Parkinson's-like disease, whereas increase in dopamine level in different places may lead to schizophrenia-like psychological problem or thought disorders. D2 receptor is basically inhibiting cyclic AMP synthesis and increased potassium conduction. It is present at the presynaptic membrane and postganglionic sympathetic nerve terminals. Its functions will be inhibition of the release of noradrenaline, inhibition of prolactin release, vomiting, and the agonists are dopamine, bromocriptine, apomorphine-like drug, whereas haloperidol, domperidone, which does not cross blood-brain barrier, metoclopramide, these are all D2 antagonists, and these may lead to drug-induced Parkinsonism. And this drug-induced Parkinsonism is again treated with atropine substitutes. Those are anticholinergic drugs like benzoxazole, trihexyphenidyl, which have already been mentioned while discussing anticholinergic or parasympatholytic drug. Till now, there are almost 5 types of dopamine receptors being invented. It ranges from D1 to D5. So, when we will discuss dopamine in context of Parkinson's disease, this will be discussed in details. Clinically, this dopamine is used in cardiogenic shock or acute myocardial infarction with pump failure. In septic shock, it produces inotropic effect, increases urine volume. In refractory heart failure with low renal perfusion, dopamine is of value. It is sometimes given in acute renal failure for diuresis with furosemide. Before dopamine theory, the existing hypovolemia should be corrected. If the mean arterial pressure is less than 70 mm of mercury, the prognosis with dopamine therapy is poor. Dopamine related drugs, phenyldopam, dopexamine, dobutamine, these are all dopamine related drugs. Out of this, dobutamine has a very significant role in clinical practice, a synthetic derivative of dopamine. Without dopamine receptor agonistic action, it is a racemic dobutamine is an agonist of beta 1 adrenergic receptor with alpha 1 adrenergic activity. It has potent inotropic effect, beta 1 and alpha 1, with only limited undesirable chronotropic effect, and therefore the lack of effect on BP is probably due to vasoconstrictive alpha 1 effect is offset by beta 2 mediated vasodilatation. This infusion, dobutamine infusion, T-half is only 2 to 4 minutes at a rate of 2.5 to 10 microgram per kg per minute, is indicated for short-term treatment of cardiac decompensation in acute myocardial infarction after bypass surgery and congestive cardiac failure. So, in congestive cardiac failure, intractable case, we are preferring dobutamine over dopamine. The potential disadvantage of dobutamine are in prolonged therapy, it may cause receptor downregulation. Rarely we will see tachycardia, but it can be seen, and arrhythmia and the development of tolerance. These are the problems with this drug. Isoprenalin, which has no action on the alpha receptor, it is a selective beta adrenergic receptor agonist. It stimulates cardiac beta receptor and bronchial beta 2 adrenergic receptor. Now, this one will produce inotropism, tachycardia and bronchodilation. It is used in bradyarrhythmia, AV block, beta blocker, overdose and torsades de pointes. And side effects obviously are tachycardia because it has only beta action, so it will stimulate beta 1 receptor and lead to tachycardia. Arrhythmias are also common with flashing of skin. There are certain alpha 2 selective adrenergic agonists. The name of those drugs are being shown in the slides. The clonidine and those drugs like the clonidine and the name is not mentioned here. The clonidine and the alpha methyl dopa. These two are alpha 2 selective adrenergic agonists. So the clonidine is basically acting at the CVS control center. Its mechanism, exact mechanism is basically not completely understood, but the possible mechanisms are activation of alpha 2 receptors at the level of lower brainstem region, that means at this region, and possibly it binds to imidazoline receptors. So alpha 2 receptors, imidazoline receptors may jointly regulate the vasomotor tone, and alonidine decreases heart rate due to its parasympathomimetic effect. Activation of presynaptic alpha 2 receptors may suppress the release of norepinephrine, and that is probably helpful to explain the role of clonidine as antihypertensive drug. Therapeutically, it is used in the treatment of hypertension, diagnosis of pheochromocytoma with anesthetic agents, postural hypotension, hot flashes, and attention deficit hyperkinetic disorders. The side effects are dry mouth and sedation, and sudden discontinuation of chlorine may lead to withdrawal syndrome. Beside this, there are preparations like brimonidine, apraclonidine. So these type of drugs are used in different other cases. Especially brimonidine is used in case of glaucoma. It will decrease aqueous humor production. Whereas alpha methyl dopa is another alpha 2 agonist. It's a substrate of dopa decarboxylase, an active metabolite of alpha methyl noradrenaline, acts centrally to reduce blood pressure, and its pharmacological effects are basically on the ventrolateral medulla, nucleus tractus solitarius, peripheral resistance, heart rate. These are all reduced with cardiac output. The pharmacokinetic properties have been seen. Elimination half-life is around 2 hours, and therapeutic uses are mild to moderate hypertension, and it's a drug of choice in case of hypertension in pregnancy. So in pregnancy, you cannot prescribe all the drugs used in hypertension due to teratogenic effect on the fetus, but methyl dopa is safe. The side effects like sedation is the most frequent side effect, and other CNS side effects are dry mouth, nasal stuffiness. Those can be seen with this drug. The alpha 1 selective adrenergic agent like phenylephrine are directly acting alpha 1 selective sympathomimetic drug, and they cause vasoconstriction. The duration of action of phenylephrine is 5 to 10 minutes. Higher concentration may stimulate beta adrenergic receptor. Hypotension induced by spinal anesthesia is one of the indication or therapeutic use of phenylephrine, or it can be used with supraventricular tachycardia with hypotension. The side effects like bradycardia and hypertension can be seen with that. Ephedrine is a mixed acting sympathomimetic. It is prepared synthetically. Also, it is obtained from Ephedrus species, and it acts directly over alpha and beta receptors, as well as it releases noradrenaline from sympathetic nerve terminals. So tachyphylaxis is the phenomenon which can be seen with this drug. This ephedrine is used in bronchial asthma as an adjuvant in myasthenia gravis and motion sickness, also in hypotension due to spinal anesthesia. There are some indirectly acting sympathomimetics like amphetamine and tyramine, which I mentioned before. Amphetamine is used in obesity, narcolepsy, whereas tyramine is a natural amine present in the food material, and this is responsible for cheese reaction in presence of MAO inhibitors. The MAO inhibitors will obviously inhibit the action of monoamine oxidase, hence the release of norepinephrine will be increased, and it may lead to severe hypertension. So the cheese material which contains tyramine like substance should not be used with MAO inhibitors in combination. So these are in brief about the drugs used in as a sympathomimetic drug in therapeutic practice. There are some sympatholytic drugs, and I will discuss these sympatholytic drugs in your lecture class. So these sympatholytic means they are the antagonist of adrenaline, noradrenaline, and these drugs are classified into two types: the alpha blockers and beta blockers. And there are some blockers which are having both alpha and beta blocking action. Those two drugs are labetalol and carvedilol. So alpha blockers can be classified into two types, a non-equilibrium type. The phenoxybenzoate is a irreversible type of blocker. The equilibrium type are competitive, non-selective ones are ergot alkaloids. There are drugs like halogenated ergot alkaloids, dihydroergotamine, dihydroergotoxin, imidazolines. There are drugs like phentolamine, tolazoline, miscellaneous chlorpromazine. There are drugs like alpha-1 selective, tazocine, terazocine, tamsulosin. It's a selective action on bladder. So it is given in benign hypertrophy of prostate, whereas the tazocine can be given in both benign hypertrophy of prostate as well as in hypertension. An alpha-2 selective blocker, that is eohimin, not used nowadays in that sense in clinical practice, whereas beta blockers are both beta 1 and beta 2. The non-selective one are propranolol, sotalol, timolol. The cardioselective ones are metoprolol, atenolol, acebutolol, bisoprolol, esmolol, celeprolol, nebivolol, and betaxolol. There are 8 selective cardioselective blockers. There are drugs with intrinsic sympathomimetic activity. That means they are having they are increasing cardiac contractility. Those drugs are pindolol, and hence it is known as partial agonist. With additional alpha blocking property, we have levetolol, which can be used in hypertension in pregnancy, just like alpha methyl dopa. Another one is carvedilol, which is having additional peripheral vasodilator property. So, and it is used in heart failure. So these are in brief about the sympatholytic drugs. So with this, I am concluding my video presentation on autonomic nervous system. Rest of the things will be discussed in the online class. Thank you so much for your patient hearing.